Good afternoon, everybody, or good morning, wherever you may be, or it may be good evening. Welcome to this episode of the Two Druggists podcast. This is our first episode of 2022. I hope everyone had a good holiday and new year. Everybody hopefully out there is safe and Omicron variant free. And we're going to kick off the 2022 podcast rotation with looking at the EUA for Molnupiravir, which is the Merck Sharp and Dohme new antiviral hitting the market. It is currently out and distributed for treatment of COVID-19. So as always, the Two Druggists podcast is for educational and information only. If you have questions, consult your local healthcare practitioner, physician, pharmacist, etc. Okay, so we're going to go through the EUA today and hit the highlights and some of the things I find interesting. And then through some of these tabs you see shared on your screen, we're going to go through some of that stuff. Interestingly, it has already been licensed in the United Kingdom as Lagvario 200 milligram capsules, active ingredient Molnupiravir. And this is actually the UK's drug monograph site. So it has good information, and you can see there's a link to the patient leaflet. So that being said, so the U.S. Food and Drug Administration has authorized for emergency use the unapproved drug Molnupiravir. It's a nucleoside analog that inhibits SARS-CoV-2 replication by initiating viral mutagenesis. It's used for the treatment of mild to moderate coronavirus disease 2019. So limitations of use. Molnupiravir is not authorized for use in patients less than 18 years of age. It is not authorized for the intention of treatment in patients requiring hospitalization due to COVID-19. Benefits of treatment with Molnupiravir have not been observed in subjects when treatment was initiated after hospitalization due to COVID-19. It is not authorized for use for longer than 5 days. And it is not authorized for use for pre-exposure prophylaxis and or post-exposure prophylaxis. Molnupiravir may only be prescribed by an individual's patient or, an individual physician practitioner or advanced nurse practitioner or physician assistant licensed or authorized to do that. So, in the EUA, there's an entire page of mandatory requirements for prescribers. So dosage and administration. The usual adult dose for Molnupiravir is 800 milligrams, which is 4 200 milligram capsules orally every 12 hours for 5 days, with or without food. You're going to take Molnupiravir as soon as possible after a diagnosis of COVID-19 has been made, and within 5 days of symptom onset. Okay, again, we're only going to use this for 5 days. And then completion of the course at the end of 5 days, you're not supposed to do another course. If a patient misses a dose of Molnupiravir, we should advise them if it's been 10 hours, they can take that dose and then resume their schedule of normal dosing. If it's been over 10 hours, the patient should not take that missed dose and instead take the next regular dose at the scheduled time. At no point should our patient double dose or make up for that missed dose of Molnupiravir. Okay. So going along here, we have no dosage adjustment for renal or hepatic impairment or for geriatric patients. We have one single dose format, that's a 200 milligram capsule. We have no known contraindications to this drug. There are a fair number of warning and precautions, and they center around embryo-fetal toxicity, pregnancy, and bone and cartilage toxicity. So again, we cannot use this in patients under 18 years of age, primarily due to the bone and cartilage toxicity observed in rats and rat studies. They found that Molnupiravir causes bone and cartilage toxicity in rats after repeated dosing, and that is in their toxicology section. and it inhibits the formation of bone and cartilage at the epiphyseal joints. So you're having bone deformation. As far as embryo fetal toxicity, there are multiple warnings about utilizing this drug in pregnant women. Prescribers have to enroll the person in the pregnancy surveillance program. You have to ensure that patients, if they are pregnant, they understand the risks and the benefits, and that's up to the provider. The other thing is patients that take this drug, starting the course, if they are of childbearing age, they must use contraception at least 4 days after stopping the course. So for that period, you have to use that. Although I can't see somebody, anyway, we won't go there. So adverse reactions, adverse events associated with Molnupiravir may become apparent with more widespread use. In other words, we don't know what the adverse events are. But from the Move Out trial, which was a trial of 1,400 people, that's 700 or so got the drug. The largest occurrence of adverse events were nausea, dizziness, and diarrhea. Although interestingly enough, under laboratory abnormalities, they did see grade 3 and 4 alanine aminotransferase and aspartate aminotransferase and creatine and lipase abnormalities. So that may be a signal there to something to watch. Under hematology panels, there were abnormalities in hemoglobin, platelets, and leukocytes, and they were rare events in less than 2% of persons in the Move Out trial. Of course, since this is an EUA drug, we have mandatory reporting for adverse events and medication errors, and they would like you to use FDA Form 3500 to do that. At this point, there are no known drug interactions between Molnupiravir or its prodrug metabolite, which is cleaved and activated once taken. So there are no drug interactions as of yet. Again, they stipulate again pregnancy. There's a pregnancy surveillance program. There's a risk summary based on animal data. It may not be used. It may cause fetal harm. Clinicians are advised to make patients aware of the benefit versus risks, and that's to be documented. Under clinical considerations, COVID-19 in pregnancy is associated with adverse maternal and fetal outcomes, including preeclampsia, eclampsia, preterm birth, premature rupture of membranes, venous thrombosis disease, and fetal death. So, the providers need to weigh those data. Again, in animal studies, we have embryo fetal development issues. When given to rats that were pregnant, they did see developmental toxicities, including post-implantation loss, malformations of the eye, kidney, and axial skeleton, rib variants, and this was at an 8x human dose. At a 3x human dose, the only abnormality they saw was a fetal birth weight reduction. Okay. So that is the rationale for do not use in pregnancy. They also gave it to pregnant rabbits and saw developmental toxicities. As far as breastfeeding and lactation, there's no data on Molnupiravir or its metabolites in human milk. NHC, which is the active metabolite, was detected in the plasma of nursing pups from lactating rats. So there's a good bet that it will probably be in human breast milk. Female and male reproductive potential, they looked at toxicity studies. They advise using contraception in people of childbearing ages. It's also recommended for males, and they want you to use this for a duration of the treatment and at least 4 days after the last dose. Okay. Again, no pediatric use due to bone and malformation and toxicity. and particularly that was seen in rats. There's no precautions for geriatric use, no dose adjustment for renal or hepatic impairment. We have no data on overdose, and supportive care would be expected. NHC, which is the prodrug, or excuse me, the active metabolite, gets metabolized under purine and pyrimidine synthesis chains, so it gets eliminated typically as bits and pieces of like uric acid. Section 11, we get into the description. Molnupiravir is a gynonucleoside analog that inhibits SARS-CoV-2. Its active form is a 5-isobutyrate ester of the ribonucleoside analog N4-hydroxycytidine. NHC is the abbreviation. Again, the mechanism of action for all antivirals like this that are analogs of nucleotides, they get in, they're picked up by the, in this case, RNase polymerase. They get incorporated into the chain and they cause chain breakage or incomplete genome synthesis. And the incomplete genome synthesis causes viral replication to stop. It goes into more detail under clinical pharmacology about NHC is phosphorylated into an active form, and it's incorporated and so on and so forth. There's no pharmacodynamic data here. There's limited pharmacokinetics from the MOVE-OUT trial and the safety and efficacy study published in the New England Journal of Medicine. Looking at the PK data, there's nothing of nothing that really jumps out at me that you can peruse that at your own discretion. So drug interaction studies, as with lots of new drugs, that's what we look for. And currently with Molnupiravir, it is not a CYP enzyme substrate, a human P glycoprotein substrate. It doesn't react with anything at this point based on the limited data that we have. However, the interaction between Molnupiravir and concomitant medications, including others to treat mild to moderate COVID-19, has not yet been evaluated. There's a fair bit on its microbiology and mutagenesis potential. And they do note in here that, and this was probably blown way up in the news about every antiviral that comes along, there is a chance of inducing some mutations in the spike protein that may affect the use of targeted monoclonal antibodies in vaccines, the public health significance of which is unknown. So, anytime you have a nucleoside analog that can induce a mutation, you can have this, although deletions, insertions happen anyway because RNA polymerase is not great. It has an error rate. This just increases it to the point where the virus is not viable. So that'll be interesting to see what happens there. So they have demonstrated the antiviral activity of Molnupiravir in mouse models, hamster models, and ferret models, all for SARS-CoV-2. So that should give everybody warm and fuzzy feelings. And typically what they found is Molnupiravir has reduced viral copy numbers, antigen levels, and in the tissues they've looked at, you have less viral antigen. So that means less reproduction, and that gives your immune system a chance to grab hold of it and eliminate it. Non-clinical toxicology, carcinogenesis, mutagenesis, and impairment of fertility. Based on the total available genotoxicity data, the duration of treatment of 5 days is a low risk for genotoxicity. Well, that's always a good thing. Again, animal toxicology and pharmacology, bone and cartilage, and pregnancy are our big worries here. And those studies are referenced in the EUA text. Although this is something that probably should bear some note, reversible dose-dependent bone marrow toxicity and hemopoietic cell lines was observed in dogs at greater than or equal 17 mg per kg per day. This is less than the human exposure. So they saw a mild decrease in dogs of peripheral blood cells. Platelet counts were seen at 7 days. At 14 days, you had further degradation. Although after stopping it, they did not see any long-term hematological toxicities. So you may see a bump downward in that while you're taking it. They did not see hemodynamic toxicities in mice, but we're not mice. We're not dogs either. So it'll be interesting to see if the noted adverse effects of platelets, hemoglobin, were related to bone marrow toxicity. Section 14 goes over clinical studies. The Move Out trial, which was published in the New England Journal of Medicine, which is right here. Molnupiravir for oral treatment of COVID-19 in non-hospitalized patients. 1,433 people were randomized into a double-blind controlled clinical trial looking at molnupiravir for non-hospitalized patients with mild to moderate COVID-19 who had a risk of progression for severe COVID-19 and hospitalization. Eligible patients were 18 years of age and had more than one predefined risk factor for disease progression. So we include disease progression risk factors: over 60, diabetes, obese, chronic kidney disease, heart conditions, COPD, or active cancer. So we have some good comorbid conditions here. And we look at the effect of molnupiravir on these patients and how they do. And again, they gave 800 milligrams twice a day for 5 days. They were randomized. 46% were Latino, 33% were European, 6% African, and 3% North American. And I'm sorry, 6% were North American and 3% were Asian. 48% of our subjects received molnupiravir or placebo within 3 days, so that's good, getting treatment started early. The most common risk factor in their study was obesity, which is one of the most known risk factors for severe COVID disease. So they go on to note that 58% were infected with the Delta variant and 20 were infected with the Mu variant and 11% the Gamma variant. Now, when you get into variants, it's kind of variant soup because RNA viruses like to mutate and shift and jump, and it is what it is. So all-cause hospitalization for acute care or death through 29 days. In the molnupiravir group, they had 48 out of the 700 patients, 6.8%. In the placebo group, they had 68 or 9.7. And their data is arguing that the adjusted risk difference is a 3% in the positive towards molnupiravir. All-cause mortality through day 29, they had 1 death in the molnupiravir group, 9 in the placebo. And we can look at some of these things. Let's see here. So here's days since randomization, percentage of patients free from hospitalization and death, although their graph is a little tough to read. I'm thinking this is hospitalization and this is death. Here's a table of the characteristics that I talked about. Again, we had a good age distribution. We had people over 50. We had obese patients, patients over 60, patient with diabetes, heart conditions. Those are all good. Here's their study. Okay. Let's scroll down here. So incidence of hospitalization and death in the modified intent to treat population. Okay. Under risk factors, you notice that your absolute risk gets lower with some of these comorbid conditions. Okay. Molnupiravir is supplied, obviously, again, as 200 milligram capsules. There is a patient counseling handout. So, again, it's licensed under Marrow, 200 milligram capsules in the UK. And if we go to the National Library of Medicine here, you see that if you put in N4-hydroxycitidine, which is the active metabolite, from 2011 to 2022, there are 30 publications. And this is a great example of repurposing a drug for a new infection. And we do this a lot in medicine and pharmacy and, off-label use. But as many of you know, antivirals is an area that we are sorely lacking in. So we've looked at this Molnupiravir prodrug against norovirus or Norwalk virus, and that would be a big boon for the cruise industry because diarrheal type illnesses and gastritis are their bane. They spread crazy in cruise ships. So norovirus would be good. New ribose nucleoside inhibitor for Ebola. That would be another good one. Having a treatment for outbreaks of Ebola that is safe and effective. That is also a good thing. So it's a candidate for that. Chikungunya virus. I hope I pronounced that correctly. Chikungunya virus, yeah. Or CHIKV is a non-specific antiviral agent with, well, here they report suboptimal outcomes. So at least they tried it against it. We're looking at enterovirus species. So again, diarrheal viruses. And they also looked at it at Coxsackie viruses, encephalitis viruses, influenza, respiratory syncytial virus, although with the bone marrow toxicities that are potential, pediatric use is not necessarily going to be there. But, for older adults in a nursing home that have RSV or influenza, this could be an add-on if this data holds. Venezuelan equine encephalitis, it's been looked at for that. So yeah, I mean, if you go to the primary literature, you're going to see a fair number of studies of this nucleoside analog and inhibitor. Apparently they had really high hopes for it for flu, but it looks like coronavirus is where it may get its traction. So we'll have to see how it does. The initial study was talking about a 50% reduction, and I think they've revised it to a 30% reduction in overall hospitalization for COVID patients. It's well tolerated. It has some reasonable pharmacokinetic data. I hope you've enjoyed this study and review of the new emergency use authorization for Molnupiravir. That's going to wrap it up for this episode of the Two Druggists podcast. Have a great day, and we'll see you at our next episode where we're going to look at Paxlovid. Thanks, everybody, for listening. Have a good day.